A patient was started on an anticoagulant therapy for DVT, and the next day he presented with features shown the implicated drug. This is not a very common side effect. This is known as the purple toe syndrome, which is seen with warfarin, and warfarin is a oral anticoagulant. Dermal vascular necrosis is being shown here, which is the how do you treat warfarin toxicity? If you're suspecting warfarin toxicity, you're monitoring it with PT-INR. If you're suspecting warfarin toxicity, stop warfarin, and then immediately you can give fresh blood transfusion or fresh frozen plasma, because that contains the clotting factors, and the specific antidote is vitamin K injection, and you give it intramuscularly. Okay. Now coming to another diagram, this is the prostaglandin and leukotriene synthesis diagram. You can see the membrane phospholipids. Phospholipase A2 is acting, and then you have the arachidonic acid, which is acted upon by the COX, which brings the synthesis of prostaglandins, and when it is acted upon by lipoxygenase, it brings about the leukotrienes. Then you have various leukotrienes like LTB4, C4, D4, E4, which acts on the cysteine LT receptors, and they bring about the bronchoconstriction. So at the level of phospholipase A2, we have corticosteroids. Then you have lipoxygenase inhibitors like zilutin. Then you have the receptor antagonists like saferlucast. And at the level of bronchoconstriction, you have various bronchodilators, which includes your sympathomimetic agents, anticholinergic agents, and theophylline group. Now coming to this image, which is the mechanism of action of an antifungal agent. So what is being shown here is there is this ergosterol. So this drug is coming and binding to this ergosterol, and it is forming a pore, and that has led to the entry of certain substances, and there is exit of certain electrolytes and all. And there is oxidative burst, there is membrane damage, there is mitochondrial damage, there is protein damage. So which is drug? Drug is amphotericin B. Okay, so drug is amphotericin B, which binds to ergosterol, form pores, and will result in cell lysis. And it is one of the drugs that we use for treating systemic fungal infections like cryptococcosis, coccidiomycosis, aspergillosis. Okay, what is the main problem with amphotericin B? It is one of the most nephrotoxic agent, and usually we have nephrotoxicity is one major problem with amphotericin. Saline hydration is given prior to giving amphotericin B to reduce this nephrotoxicity. But another thing you should note that we do not mix, though we give pre-saline treatment, we don't mix amphotericin B in normal saline, we mix it in dextrose. Another common side effect seen with amphotericin is hypokalemia. So you always have to give potassium infusion also in a separate line whenever you're giving amphotericin. And to reduce this nephrotoxicity and other effects, now we have the newer liposomal amphotericin B that has less side effects, but the main problem is the cost. So this is a figure which shows the mechanism of action of the majority of antifungal agents. So right from cell wall, you have echinocandins, which acts on this beta 1,3 glucan synthesis. So you have echinocandins and nicomycins, which inhibits the chitin. Then you have the cell membrane. On cell membrane, you have the amphotericin B, which binds to this ergosterol to form the pores and channels. They belong to the group of polyenes. And then you have the intermediate steps that is involved in synthesis of ergosterol. So that is inhibited, like squalene converted to lanosterol is with the help of squalene epoxidase. That is inhibited by the allylamine group. And examples of allylamine group is terbinafine, naftifin, and amorolifin. Then from lanosterol to ergosterol is inhibited by the azoles, which is the most common group that we use these days. And this is mediated by 14 alpha demethylase enzyme. So that is inhibited by azoles, which is again divided into imidazoles and triazoles. Among azoles, please remember voriconazole, which is the voriconazole. Okay, this is the drug of choice for invasive aspergillosis. And remember, it can cause V for visual disturbances and also can cause QT prolongation. And another newer azole is posaconazole, which can be given, which is available, posaconazole, which is available orally, and it can be given for mucormycosis. Okay. Now we have flucytosine, which interferes with the DNA synthesis, and griseofulvin, which interferes with the microtubule formation. So this is in nutshell the different mechanism of action of different antifungal agents. Okay. Now we go to this diagram, which is the Parkinson's drugs acting on Parkinsonism. So here you can see why are we giving it as levodopa? Why not dopamine? Because dopamine cannot cross the blood-brain barrier. So dopamine, when we give, almost 90% is getting decarboxylated in the periphery. Only 1 to 2, very less amount crosses the blood-brain barrier. So here you have the dopa decarboxylase enzyme. So we have to give a peripheral dopa decarboxylase enzyme inhibitor so that more of levodopa crosses the blood-brain barrier and reaches the site. So what are the examples of dopa decarboxylase inhibitor, peripheral dopa decarboxylase inhibitor? You have carbidopa, bensericide, etc. Then you have the metabolism inhibitors, you have the COMT inhibitors, and you have the MAOB inhibitors. So which are the COMT inhibitors? You have tolcapone and entacapone. You can see here COMT is available both peripherally as well as centrally, whereas MAOB inhibitors is present only in the central. So here you have rasagiline, salicylic, which is MAOB inhibitor. You have tolcapone, entacapone, which are COMT inhibitors. The difference is tolcapone has got both peripheral and central action. Entacapone has only peripheral action. But the problem with tolcapone is it has liver toxicity. So it has got a black box warning for that. Peripheral decarboxylase inhibitor, you have carbidopa and bensericide. Okay, so that is regarding the dopamine metabolism. Okay, now don't get hassled by this diagram. What is this diagram basically on? On the anti epileptic drugs mechanism of action. Okay. So anti-epileptics, what is basically happening in epilepsy? There is a disordered firing of neurons. So how can you control this? By either controlling your ionic, the impulse transmission is through sodium channel and a calcium channel. So you can give sodium channel blockers, you can give calcium channel blockers, then you can increase the inhibitory neurotransmission. What is inhibitory neurotransmission? Your GABA chloride channel. So you can increase the GABA chloride channel transmission, or you can decrease the excitatory neurotransmission, and excitatory neurotransmitter is glutamate. So you decrease the glutamate neurotransmission. So glutamate is acting through different receptors. You have NMDA, AMPA and kainate receptors, and most of the newer ones act through these glutamate and other novel mechanisms. Majority of the conventional agents act by blocking the sodium channels, that is your phenytoin, carbamazepine, phenobarbital, all act by blocking the, we'll see here, by blocking the sodium channel. So sodium channel, you have agents like phenytoin, carbamazepine, phenobarbital. If you see newer agents like lamotrigine, all acts by blocking the sodium channel. Now calcium channel is mainly involved in the T-type calcium channel, mainly involved in absence seizures. So we have drugs like ethosuximide and sodium valproate, which acts through calcium channel. Then you have the GABA chloride channel activation. Conventionally, you have learned about benzodiazepines and barbiturates that acts through, sorry, barbiturates does not come here. Okay, I made a mistake. Okay, you have the benzodiazepines and barbiturates, which acts through GABA chloride channel. Then we have a whole lot of newer anti-epileptic drugs that acts through this GABA chloride channel. So one is gabapentin, pregabalin. Another one is tiagabin. Sodium valproate acts here also. So one thing you can see here, all of this have got GABA in their name. Okay. Okay. So this GABA chloride channel we'll look first, and then we'll go back to the complicated picture first. So here you can see normally it comes and binds to this GABA chloride channel. You have the barbiturate and you have the benzodiazepines. Then you have gabapentin pregabalin. Pregabalin is a prodrug of gabapentin that will stimulate the GABA release. The mechanism is not very clearly understood. Then you have this tiagabin, which is a GABA T for transporter inhibitor. So it inhibits the reuptake of GABA back into the cleft. GABA remains there and brings about the action. Then you have this bicabatrin. You can see GABA transaminase. It inhibits GABA transaminase enzyme so that more GABA is present in the cleft. Similarly, sodium valproate also inhibits this metabolism of GABA and it remains more in the cleft. Now when we come back to this diagram, you can see here voltage gated sodium channel. If it is given as drug A, you have phenytoin, carbamazepine. Among newer drugs, you have lamotrigine, lacosamide, zonisamide and all acts by a sodium channel blockade. Then you have, if this is B, you have benzodiazepines, barbiturates, tiagabin, which inhibits the reuptake, gabapentin, pregabalin. Okay, so uh, we are done with that. Then, so GABA is finished, sodium channel is finished. Calcium channel, you can see here, C. T-type calcium channel, you have ethosuximide, even sodium valproate acts by all these mechanisms. Then you have this potassium channel openers. You have this reticabin, which acts both postsynaptically as well as presynaptically. That is called as reticabin. Then you have this glutamate receptors. Under glutamate receptor blockers, you have AMPA receptor blocker, which is perampanel. You can see AMPA in its name itself, perampanel. Okay, and then you have done perampanel, which is a glutamate receptor blocker, which is AMPA receptor. Then a novel mechanism is by this levetiracetam, which blocks the synaptic vesicle 2A protein, which is present on the synapse, and bring about its anti-epileptic action. So this retigabin, perampanel, levetiracetam, tiagabin, gabapentin, all these are newer anti-epileptic agents. And this is a very important chapter. Anti-epileptics as such is very important, and image is also very important.